Assalamu alaikum. Starting our long clinical consultation day with Mr. Ali, 45 years, with complaint of short of breath. Okay, you can see the timer now.
Hello.
Ready?
Yes.
Yeah, here you go.
Hello, I am Dr. Mutwalli, the doctor in clinic today. May I confirm you are Mr. Ali?
Yes, doctor, I'm Mr. Ali. I'm
45
45
years?
Yes, 45 years.
Okay, welcome, Mr. Ali. I am here today to discuss your health condition and may I examine you. Is this okay with you?
Yes, doctor.
Okay, Mr. Ali, can you tell me what brings you today to the clinic?
Yes, doctor, you know, I have this is difficult of breathing. I will suffer from this is actually for a long time, and nowadays it become more progressive, and I will suffer even if I want to go very small step from room to room. I suffer from this difficulty of breathing.
I'm so sorry about you, about Mr. Ali. I'll try to help you. Do you need any oxygen now or you feel comfortable?
No, I'm okay, doctor.
Okay,
Thank
Mr.
you.
Ali, so as you tell me that you have some difficulty in breathing for a long time. What do you mean by long time? It is 4 years, you mean, or 4 months?
It is actually, doctor, it is around 2 years.
2 years. And it is diagnosed with any medical condition?
No, doctor. No, I didn't see any medical diagnosis.
And through those 2 years, it is become more worse, or it is come and go?
Actually, it started gradually. Sometimes I feel I'm okay, but nowadays I feel it is more progressive.
So, what time exactly you feel that you feel that that is become worse?
No specific time, doctor. All the day.
And it is how many days you feel this worsening in your symptoms?
A long time, as I told you, doctor.
So you said that you have worsening in last days. You mean this is last month?
Yes.
Okay, and with this shortness of breath, you find that anything worse, like when you walk, when you climb the stair?
Whatever I want to do, anything, I feel this is more worse. And nowadays, even if I at rest, I feel difficult of breathing.
I'm sorry for you, Mr. Ali. So even at rest, so this means that you can sleep good or you find difficulty sleeping?
Yes. But yes.
You found that you may woke up with like suffocation or difficulty in breathing during
No.
sleep?
No.
Do you use mini pillow to can sleep more than usual?
No, I use one pillow and I'm comfort.
So this become at rest also. If you know any activity, you will feel also difficulty breathing.
Yes.
And this associated with any chest pain?
No.
Any cough?
Yes, I have cough, doctor.
And this is has dry or include phlegm?
No, dry cough, doctor.
And you feel any wheezy chest?
Noisy chest, no.
Yes, noisy, no. So this cough also for 2 years?
Not for actually for 2 years. This is cough like 6 months.
6 months. And this is always a day?
Yes.
It's increasing at sleep or in supine position like recumbent? No?
No, I didn't appreciate it, I think.
No. Do you have any acidity or any feeling like stomach upset?
No.
Stomach upset, no? Okay. Do you have any medical condition that I should be aware of?
Like what, doctor?
Like any disease, like diabetes, high blood sugar, high blood pressure,
No,
any joint problem,
no.
any skin problem?
Skin rash? No.
No. Any surgery in the past?
No.
Are you taking any medication, Mr. Ali?
Yes, sometimes I take this ibuprofen.
Can I ask why you take this ibuprofen?
Yes, thank you, doctor. I take this ibuprofen because I have back pain.
Mm-hmm. Where is exactly your back pain?
In my lower back.
Mm-hmm. And what time it started this pain, Mr. Ali?
Actually, this pain, it is around same. It is around 2 years.
Mm-hmm. And you feel any consultation with your GP about this pain?
No, whatever I take this ibuprofen, I feel I'm okay.
Mm-hmm. And you feel this ibuprofen can make your breathing difficult or no relation?
No, it can help me only I take it from this is back pain.
Any other medication you use, Mr. Ali?
No,
Even over the counter or herbal?
no,
Okay. Do you have any recent high temperature?
no,
Any night sweat?
no,
Any weight changes?
no, doctor.
Mm-hmm. Do you feel your heart like racing or feel your
No,
heart beat? No?
no,
Do you have any dizziness?
no.
Do you have any swelling in your limbs?
In my leg, no.
No. Do you have any weakness anywhere in your body?
No.
Any visual problem?
No visual problem, but sometimes I have redness in my eye.
Mm-hmm. This is for how many years you found this
No,
problem?
only like 1 to 2 months.
1 to 2 months.
Mm.
And do you seek any consultation about it?
No, actually, it don't bother me too much, but I feel my eye is red.
Red. And this is painful or no?
No,
Not painful?
not so painful.
But you have no problem in vision at this time if you have red eye.
No, I see well.
And no sensitivity to light at this time.
No,
Okay. Do you have any problem, tummy pain,
no,
any throw up?
no,
You have any change in your bowel habit?
no.
Any change in your water work?
Like what, doctor?
Like you have frequent going to bathroom or painful
No,
passing water? No pain on passing water work? Frozy water, like you
frothy,
find
no,
it? No.
no.
Sorry. Do you feel that you can't control your water work?
Yes, I can.
You can control. Good.
Yes.
No any problem. So, what do you do for living, Mr. Ali?
Actually, doctor, I'm a teacher.
How this condition affect your work?
Too much, I want to go stair up and down, and this affect me.
I'll try to help you by referral to social worker. He can help you for this by this issue. Are you smoker, Mr. Ali?
No.
Are you drink any alcohol?
Yes, like 10 unit per week.
Okay. Are you sexually active?
Yes, I'm married.
Sorry asking you this question, but it's important in your in my interpretation your condition. So, do you have any sexual relationship other than marriage?
No.
Okay. Any using of any illicit drug?
No, doctor.
Any tattoo in your injecting sharing needle?
No.
Do you have any family condition of note, any disease run in your family?
No.
Do you have any family condition like you, like any back pain and shortness and breathing difficulty?
No, doctor.
Any family condition or joint problem?
No.
Okay. May I examine you?
Yes.
Okay, I need to check if there is pallor.
Not
If
there.
there is, if there is apparent look of fatigue or breathlessness.
Yes, patient some decent difficulty of breathing.
Okay, I need to check the hand for any joint problem.
What joint problem you wanted?
Any deformity or swelling in interphalangeal joints?
No. Then?
Okay, then I'll need to check the pulse, the blood pressure.
Pulse for what?
Regular pulse. There is any different in rhythm? Regular?
Yes, regular.
Any collapsing pulse?
No collapsing pulse.
Okay, I need to check the eye for redness or any eye movement. I'll check. No problem.
Yeah. No redness.
Okay, I'll check I'll check first the heart. I need to check the apex and auscultate the heart for any murmur.
Where?
Aortic area and
Yes.
the apex. There's murmur?
No murmur.
No murmur. Okay, and the chest, I'll auscultate the chest. There is any added sound, any breathing problem in air entry?
What you expect, doctor?
I need to check exactly more the apex or the upper loop of the lungs.
Yes, there is a
Crepitation.
Yeah.
In upper loops. Both upper loops or unilateral?
In the right side.
And if I'll make a patient take deep breaths, if there is any limitation in expansion, I can notice. No?
Yes, there is decrease in expansion.
Expansion, okay. I now move to lower limb. Is there any lower limb edema?
No.
Any pigmentation or any skin lesion I can found in lower limb?
Like where, doctor?
Like on chin or on?
No. Yes.
No.
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 Yes.
Okay. What is your concern, Mr. Ali?
What I have, doctor?
Okay, from you tell me, Mr. Ali, we need to make further test for you, but most probably you have a condition related to your back pain, and this condition called ankylosing spondylitis. Don't bother about this name; it is medical term of medical conditions that
2 minutes.
you have some problem in your immunity, on your defense system, that he can attack some parts of your body, especially the joints, and in your case, it attack the joints of your back, and this cause may be the cause of your back pain. For your difficulty in breathing, this is also the same problem that like a bad effect of this disease that cause some scarring in your lung tissue, and this scarring progress by time and cause this difficulty in breathing. Are this clear? Is this clear, Mr. Ali?
Yes, doctor. It is curable.
Okay, Mr. Ali, we can control this disease. I'm sorry to tell you that this disease is not curable, but we can control the disease in early stage, and we can give you some medications that will slow the progression of this disease and will like your life to be easy or comfortable. do you have any other concern with Mr. Ali?
No, thank you, doctor.
Okay, Mr. Ali. So for the time being, I'll refer you also to occupational health worker, so he can guide you if you need any help at home. Are you supported at home? Anyone can help you?
No, I'm supported, doctor. I can do it. Thank you.
Thank you. Mr.
Okay.
Okay, time is up. I give you 1 minute extra to ask something. What you want? What you'll ask
Let's see.
in the social.
Social. I think maybe driving يعني but
Yes.
not driving.
Yes.
Driving.
Yes.
Yes. Is
But
it?
in driving here, it affected.
Yes,
What
because
do you
move
think?
the neck.
Do you feel that your back pain affects your drive, Mr. Ali?
No. Do you drive?
Do you drive? Yes or no? No?
Yes.
Okay.
I
And
need
this
Is it the back pain or the neck limitation of moving?
she has neck pain?
Neck limitation, movement limitation in the neck. Neck, okay, I'm closing.
But I
Okay,
think maybe okay. But I think she has like only back pain. I ask about any
You
weakness
diagnose
in
the
her head.
patient as ankylosing spondylitis.
Hysterectomy.
What do you
Okay.
think about? Okay, time is up. Let's go to the exam now.
Okay. Yes.
Okay, yes, you can start now.
Okay. Present your case, please.
Okay, this middle-aged man complained of shortness of breath for 2 years that worsening through the last 6 months or 2 months. He has also dry cough and this shortness of breath like severe, like it now come at rest. He has past medical history of back pain that not diagnosed. Most probably this is like ankylosing spondylitis, and because he has also some feature of ankylosing spondylitis like anterior uveitis, I think, from the red eye that recurrent for him, and from the apical lung fibrosis or the upper loop fibrosis of the lung. For by examination of this patient, he has upper loop crepitation and the diastolic expansion, most probably for fibrosis. And I didn't check really the back. You need to check the back case.
Yes. So, what feature in suppose that this is your case, it's ankylosing spondylitis. What other feature you wanted to see in examination?
I'll do a test of I can't remember the name, but for bending the patient to see the limitation.
Yes.
Again, sugar. Yes, sugar test. That is this less than 10 centimeter increase in this increase in distance when he bent forward.
Yes. Yes. And then
other thing to examine the cardiac examination, but this is okay because it may be associated with aortic regurg.
Yes, an extrapital wall test. So, what's your differential diagnosis?
My differential, it is apical crepitation, upper loop crepitation, and the dry cough. It is most probably fibrosis. Fibrosis in this age may be related to like rheumatology condition or maybe idiopathic pulmonary fibrosis also. Also, it can relate it to any work if he working in industry that causing fibrosis of lung.
Other thing like seronegative arthritis.
Yes.
You want to add?
Seronegative arthritis, yes.
Yes.
Like psoriasis.
Yes, yes. So how you investigated your patient?
I'll do for him basic investigation, including full blood count and renal function and the kidney function and liver function. Also inflammatory markers. Also, I'll investigate autoimmune antibodies. Also, I'll investigate the urine test, urine analysis. I'll do chest X-ray and back X-ray. Lower back X-ray. I'll search for sacroiliitis, and in the chest, I'll search for any like reticular shadows.
Okay, and then
we can also check for complication, like we'll do echo and ECG. I'll also like to check the eye for refer to ophthalmologist also.
So how you will manage your patient?
This patient, we will counsel him about his disease and what is the progression and prognosis of this disease. And we will include in our management physiotherapist and occupational therapist. Also, we will include ophthalmologist and rheumatologist. I'll do pulmonary function test and assess the condition of fibrosis. And we can start off DMARD at this stage of the disease to prevent progression. We can also help by some exercises. I'll advise about exercise that it is fine exercise like walking, like swimming.
Yes, swim. Thank you. Thank
Okay,
you.
time is up. Yeah, thank you, Dr. May, for the case. Well done, Dr. Aisha. I will listen to Dr. Aisha comment, then I will. Yes, you can start, Dr. Aisha.
Do well. Yes, in the history, you want to ask. I feel you take it more time in shortness of breathing. Okay, like 3 minutes. Okay, if you just ask when this started exactly, since start decrease or same, and how many distance before you will go before you feel this is shortness of breathing, and then ask it about the respiratory symptom. Then ask like you will ask it. You need to ask it about driving good. Dr. Basim, he give you 1 minute, and then he said to you, you catch actually the disease when he said to you have back pain. Then ask him, rather than this is ibuprofen. Did you want when you work at morning? Did you have a stiffness in your back, and how is this is back pain? And you want to analyze the back pain. You didn't analyze the back pain, side, nature, radiation, duration, any pain in your body. Then in examination you want to already you catch it diseases. Then examine the ankylosing spondylitis. Yes, you do well. You examine the vital sign of the patient. You need is that, and pulse of the patient, eye, test for apical fibrosis, aortic rigor. Then you want to examine the back. You want to examine the back, okay? Sign in the occipital wall test. You want to examine the back for a modified Schubert test. Otherwise, you do well. And thank you.
Thank you, Dr. Mike.
Yeah, thank you, Dr. May.
Really, the back pain. I forgot about the back.
No,
Yes,
actually,
exactly.
And I didn't analyze the back good, yes.
No, actually,
Not
do.
only analysis. Yeah,
Yes.
not only analysis. Actually, if you examine the ankylosing signs while you examine the patient, you will get the full mark. But I was wondering why you are not examining the ankylosing itself.
I forgot.
Examine as, yeah, this is a case of ankylosing, and you touch the diagnosis, but you
Yes.
didn't examine for ankylosing. And she tried to ask you for the pulse, what you want by the pulse. Yes, you can ask her about the bradycardia, but you ask the nature of the pulse for aortic regurgitation, collapsing pulse. This is good. And ankylosing, apical fibrosis, also good. but the neck, the movement of the neck, the limitation, the back, the exposure of the back, you might have scoliosis or kyphosis. So you should
Yes.
examine the patient
Should
back.
examine the back. Yes.
Yeah, totally. From first vertebrae to the last coccyx. For the limitation, for shoulder, modified shoulder, and for the kidney as well. If the patient has amyloidosis, this is one of the A's. And the leg, you ask for the leg examination as well. And she told you, what do you mean by the leg? Actually, it was an Achilles tendonitis. This is one also of the A's.
Yes.
Yeah.
How will I
Whenever
check
you need
Achilles? Just pain or
redness and tenderness, okay, inflammation.
better
But
I'll
in
ask.
general,
Yes.
yeah, in general, you did great, Dr. Aisha. But I can tell you that you will never forget the ankylosing examination after this
Yes.
case.
This is good
Yeah,
for practice.
yeah,
And
this is
I
good.
really, yes, I not take more time for in shortness of breath because this case already long. So I need to shorten my time for examination.
Yeah,
This
yes,
is practice
exactly.
for يعني about that. This is will take it by practice.
Yes.
Yes, exactly. Yes. Even the driving, with the time, you will never forget also that the only vertebral disease or inflammatory disease or rheumatological disease to ask about driving and closing case.
Yes.
Okay.
Okay.
So
Yes.
let's start from the beginning. Short of breath as analysis, onset, course, duration, any previous attack, 2 years, long time. The good thing also, you offer oxygen to the patient. This is very nice to offer oxygen if he feel or if you feel like the patient is discomfort. The timing, exact timing for the short of breath, is it morning time or day or night or evening? What was the short of breath? The exercise, anything improve, the sleeping pattern, the pillows, the rest. All this question was okay or wait, okay. The chest also a relevant system. Chest cough, it was dry cough. This is going with fibrosis. Noisy and or wheezy, or supposed to ask noisy breathing, not wheezy or wheezy
Noise.
chest.
Yes.
Yeah, noisy
Okay.
chest, yes.
Mm.
And then they analyze the cough for dry or assumed phlegm, any acid test. Yeah. So you can ask this question to rule out asthma because what asthma in such age is important differential, and you can put it in the differential in this
Yes.
case.
Other
Yeah.
autoimmune, yeah. Or other allergic condition.
Allergic or even as a common a common chest disease or common respiratory problem, yes, because the presentation is short of breath. Okay, the
Yes.
cardiovascular other relevant system in such case, cardiovascular chest pain, any awareness of heartbeat, swelling of the legs. Then other quick system review for the CNS, you did great for that. And the vision, you asked about the vision, and she told you I have red eyes, anterior uveitis, the GI also, the genitourinary. And she asked you what you mean by genitourinary, or what you mean by water rot. So immediately you can specify frothiness of the urine.
You only. Yes. Okay.
Yeah, due to amyloidosis as a chronic disease. The amyloidosis as a complication of chronic disease. You ask also about the joint, and she gave you back pain, but unfortunately you didn't analyze the back pain. You ask only for the side. It was lower, but you didn't ask stiffness, the movement improve, the rest improve, to reach that it is related to inflammatory disease or inflammatory back pain. So to confirm the diagnosis and to correlate the sign and symptoms to the underlying cause or disease, which is ankylosing spondylitis. Skin rash, also good to ask. Then family history, you ask travel, it's okay, you didn't ask, but you can ask because short of breath. You can also think about any disease related to travel history, like pneumonia. So you can ask only one question. Did you travel recently or before? The medical, you cover it well. This time you ask for the long-lasting disease, the surgery, the medication, the herbal, and she give you history of profen for the back pain to confirm our diagnosis. The medication here also is important to know because it might be uh, indication of or thinking about
fibrosis.
kidney affection or amiodarone, yes, as a complication if the patient has heart disease. So to rule out any history of drug-induced fibrosis and to think about the complication of non-steroidal, especially if the patient taking over-counter medication.
Yes.
Yeah, the question for the partner and other casual relationship. So you told him you have any sexual relationship apart from. So the question is casual relationship. You have any casual relationship? Okay. Try to ask in this way. So it's understandable question. Do you have any casual relationships? That's enough.
Okay.
Then, yeah, the illicit data twin piercing, also the constitutional symptoms you asked earlier from the temperature, the sweat and weight, change of the weight, the job, the smoking, the alcohol, and I wished to ask about driving in the same questions. This package of occupational, so add to them driving, and you can remove driving if no relation to the case. But in such case, with the time, and if you repeat this case again, you will know that ankylosing affect the driving by limitation of the neck while driving. And if you feel like your question doesn't make sense for the patient or for the examiner, you can ask about the impaction of the driving or impaction of the symptoms or the sign to the driving. Do you feel like your driving affected by your disease? So if he say yes, you can consider stopping his driving in order to save him, and save others. This is related to the history taking. During the examination, I think, yes, as I said, you were lost what to examine in this case. But you examine some of the positive finding, which is in the hand pulse, it is related by either uh, bradycardia or the pulse as aortic regurg, and you will find collapsing pulse. You can also, as you did, hand for deformity for any joint, but I think it will be negative. This is not a hand or a small joint affliction. It will be large joint like sacroiliac. Then the face or the eye, you discover or you ask for the eye redness, which is important to rule out anterior uveitis. Then the heart is very important for aortic regurg as a murmur. You specify what you want to examine. First, to detect the apex and to auscultate the murmur over the aortic area, especially in the sitting position in the left third intercostal space, while the patient sitting and after exhale. This is the specific murmur for aortic regurg. Then the apical fibrosis, you auscultate the chest, especially at the back, and you can also do the expansion. It might be reduced. The expansion will be reduced. Also, you might have some percussion or dullness in the area of the fibrosis. You might have. And the last thing, auscultation in respiratory crackles, not a change or not cleared after cough. You should ask the patient to cough. The last thing, as you did, before the legs, you can also ask for monotable kidneys or vulnerable kidneys for amyloidosis. Then the tendon acheilitis, the last A in the complication. So our differential in this patient, as you give and closing in the first, then for me, I can put bronchial asthma as short of breath, not as a finding, as a short of breath. But as a finding, I can give occupational fibrosis or occupational pneumonitis and TB, especially if there is history of travel and contact with sick patient. By the way, one point to be added If you want to roll out my differential, any exposure to bird or any exposure to animal is important for alveolitis. But it will not be apical, by the way. It will be basal, more basal. TB, yes, could be apical, but it also should be there in the history. You will find any sinister signs and symptoms like night sweat and night fever, along with lymph nodes and contact with sick patient with or positive positive travel history. This is for the differential. So again, I can put ankylosing, occupational TB, and for me, I can add also bronchial asthma as short of breath, but the asthma will be different in presentation. You can say that against asthma, there is no wheezy chest, and the cough can be with asthma as a dry cough. Silicosis, any occupational, I didn't specify why, because you can specify, but he will say to you it's rare. But occupational is a general term. You can put any term under the occupational, silicosis or asbestosis. Of course, it will be included in the occupational history. What the job? And if he give you a job related to any exposure to any industry or factory, it will be one of the differential, specify the exposure. You can ask also in details what's the previous job or what was your job or what is the substance or the material or mineral you were working in, like minerals, for silicosis. It will be clear for, I think, charcoal exposure or coal. Sorry, coal, not charcoal, coal. So you can specify whatever the exposure if you found positive occupational history, exposure to any substance. But if negative and his job is away, like this patient, teacher, so you cannot put it. But you can put occupational like exposure to any animal or bird. He might have some bit in his home or farmer, also it will be related. So it's a wide terminology and you can put under this term a lot of differential. But as this patient is not exposed to any of these, you cannot specify, but I can say occupational. Okay, on examination, ask patient to move neck by side. Of course, this is what Dr. Aisha missed. So what you miss, Dr. Aisha, is head or occiput wall test. You ask the patient to stick to the wall and you measure the distance and ask him to try to touch the wall by his occiput, and he will never touch. And the distance will be more than 5 centimeters. This is
What
for
is this test?
occiput wall. The occiput,
Occiput wall. Okay.
yes, he will stand in front of the door and his
Yes,
back touching the
I
door.
understand
Yeah,
the
yeah.
test. Yes, okay.
Oh, okay. Okay, this is the first test. The second test, move your neck in all direction, right and left, front and back. Okay, you can do it by on yourself, right and left, forward, backward. You will
Yeah.
find also limitation.
It's
You will ask
limitation.
him. This is
Okay.
yeah, this for the neck. For the column, vertebral column, you ask him to bend right and to bend left. Also, you'll find limitation. You ask him to bend forward and he will not reach lower than his knee. You ask him to touch
Touch
his
the
knee.
toes, yes? Knees or
Never he
toes?
will reach. Yes, he will never reach the toes, but you will feel levitation. Suppose
Okay.
you can do it. The normal person can touch, but for him, he cannot touch. Okay.
Yes.
And then the modified Schubert test, you will ask for tape and you specify the point in the back in the same level of anterior superior iliac spine. This is the first mark. Then you will count 10 centimeters above this mark and you will ask him to bend forward. Suppose this distance in normal person will exceed 15 after you mark 10 centimeters from the point I told you. But in this patient, it will be less than 15. He cannot reach more than 15.
Okay.
Okay, this is what you miss in the examination of ankylosing in the back. Of course, you did the screening for ankylosing like MRI. It's a diagnostic in the early stage of ankylosing for the sacroiliac joint. But in the late, you can do X-ray. It will show it can be diagnostic for sacroiliitis, inflammation, I mean. And for the back, you will find bamboo test, sorry, bamboo sign,
Delete
and
signs. Yes.
yeah, bamboo sign, and there is also sacrophyte, and there is also what's called the posterior. Let's someone can remind us. The spine, yeah, the spine will be the spines at the back will be fused. Yes, fused. It will be fused together, the back or the spine at the back. Okay, this is for the finding in the MRI and the X-ray for the chest. Sorry, for the dorsal spine, along with the MRI for hip or sacroiliac joint. Don't forget the X-ray and HRC chest for the finding in the chest. And always remember the general investigation, specific investigation. You can do also HLA 27, HALA 27, and specific for this disease. Also, other inflammatory marker is CRP, along with the kidney function. This also for general. And you can also mention the urine dipstick for proteinuria if the patient's kidney affected by either non-steroidal or as amyloidosis affection. Then you can also think about the investigation for the complication like apical fibrosis. You can do a chest X-ray, high resolution CT chest, pulmonary function test, restrictive pattern, along with echocardiogram for aortic regurg, ECG also for any arrhythmia, bradycardia, and ultrasound for the kidneys for amyloidosis. I think we covered this topic well. The management. Don't forget also to mention multidisciplinary team approach because a lot of specialists in this case, orthopedic, ophthalmologist, rheumatologist, and pulmonologist, along with respiratory therapist and social worker, occupational worker to help the patient at home, occupational therapist. And you can also ask patient education and counseling for graded exercise, swimming, and some sports to help to relieve the stiffness. And the pharmacological, 2 lines of non-steroidal anti-inflammatory. Then, if not responding, you can think about monoclonal or like adalimumab, etanercept. This is for the management and pharmacological management. I think we covered this topic more than enough in details for the history and the examination, investigation, and management. Before the question or comment, you can write your case, Dr. Aisha from Dr. May, and I will read the message. Yes. An examination ask movement, yes, move by the sides, also trunk, there is limitation in the movement, yes. Coal worker, pneumoconiosis. This is for silicosis, I think, yes. Dr. May, you have Mr. Bell, 42 years with complaint of double vision. Any question, any comment before moving to the next scenario? I think ankylosing as a case, very common in the exam. And as LCC, it's expected to find this case in especially the tests and the examination for the ankylosing spondylitis. Very important. It's one of the ideal long clinical consultation. Why? Because of the association. long
Did they
long
did they ask us to do the test in the exam, or just
what's the
to
oxybat?
offer? Yes,
No,
or
you will
the
do.
or the
No, to diagnose. Yes, it's this case. It will come to test you how you can deal with this patient or how to diagnose
mm,
the patient clinically. By the way,
mm,
the clinical cases and basis you can do certain examination ankylosing, rheumatoid arthritis, and I
thyroid.
think yeah, thyroid exactly.
Mm-hmm.
These are the common and the clinical case. You can do a lot of tests or steps in the examination. Apart from this, it will be like non-specific examination. But thyroid, you will do special steps for the examination, starting from the hand, going to the eye, then the neck for the thyroid gland itself. This is for thyroid. And closing as we did today. And the third one, rheumatoid, you will examine the hand, all the hand examination by deformity and swelling, effusion, specify the deformity, the ulnar deviation, all these things. Then look, feel, move. Then the forearm nodule. So the elbow, I mean, in the nodule, going from the hand to the chest, also to examine for fibrosis or nodule or effusion or bronchitis obliterans or obliterative bronchiolitis. So these are the three. So I can say this is for the long clinical consultation. Why MS can come here, but MS can come also in the neurological stage. Multiple sclerosis is also one of them. Myasthenia gravis as well. Also, there is some specific tests to do. You can add to the three cases I mentioned. So rheumatoid and ankylosing, thyroid, and myasthenia gravis. Okay, these are the common high-yield topic in long clinical consultation. And they have specific tests or steps to do in the examination. Bronchial asthma, it's not specific. You could do chest examination and you can find bronchial asthma, for example, in the chest, COPD in the chest, multiple sclerosis in the neurology, Crohn's in GI. You can, but this topic, you can put it as a specific or high yield topic in the non clinical consultation. So all of us should be prepared well for these cases. How to examine and how to do. Do I need to ask all causes of dry cough and all the causes of back pain in this case? It's not all the causes. You can say the common causes. For example, you can ask for dry cough in this patient, rule out asthma. So asthma one of these common differentials. So you can ask by the noided chest. Back pain, whenever you will know that this is ankylosing and inflammatory back pain, so no need to ask others. What other what other disease that cause back pain, which is inflammatory back pain? I think ankylosing on the top and other disease will not present with other symptoms like ankylosing with chest fibrosis or apical fibrosis. So show the examiner that you
IBD
are
and
doing
reactive arthritis. Yeah,
reactive
inflammatory. Yes.
arthritis.
And IBD may presented with back pain, inflammatory back pain, as a differential
Excellent,
diagnosis. Yeah.
excellent. But yeah, but what the presentation will be? It will be bronchial asthma. Sorry, it will be short
No.
of breath. No, it will be abdominal pain. It will be
Yeah,
loose
yeah, yeah.
motions. So it doesn't make sense to ask about this differential.
Yes, you have
You
to
said
explain.
you said IBD and what the other? IBD
Reactive
and
arthritis ask about
yes,
soreness in the mouth and private areas.
reactive arthritis. You're right. In
And
such
psoriatic
case,
also. All these three are differential.
Psoriatic, yes, it's very important role psoriatic in this fish. Thank you for reminding.
Yes.
Yeah, because psoriatic also can present with such kind of back pain or inflammatory arthritis. So it's important to ask about nail change. Sorry, I didn't mention this, and thank you, doctor, for this. It's very important, the psoriatic in such case. But again, it will not be the presentation of short of breath. But better to ask any nail change and the hairline for any association of psoriasis. It's important, and the flexor and the extensor area. However, it's not as if the patient came with back pain itself or joint pain itself. It make different approach. But this patient came to with short of breath. Why I will think about psoriatic? Yes, of course, I can roll out psoriatic by certain steps like hairline examination and the nail change. That's it. These are the two steps I can do just to show the examiner that I thought about psoriatic arthritis. But psoriatic arthritis, by default, it will not present with short of breath or apical fibrosis.
I mean, it has
Okay,
it will be excluded during history. And after that, you can exclude it. Yes.
you can exclude by history, you can exclude by
Yes.
examination, whatever. But if the patient came with back pain or joint pain in this type of complaint, you should rule out all causes of seronegative, not only the psoriatic. I will think about, as you said, reactive. I will think about,
Yes, yes, as
uh,
I said to you, the four
yeah,
seronegative as IBD, psoriatic, reactive, and ankylosing spondylitis.
excellent. If the complaint will be different, if the complaint is
Yes,
back
to be
pain or
secluded
joint
during
pain.
history.
But
Yes,
if short of breath,
any
now I
loose
want to think
motion. Mhm.
exactly. Yeah, this is important also. So I can't say psoriatic in the history. I will ask about nail change, or I will
Yes,
examine
skin rash.
in quick review. Yes, but I will not put it in the differential. Why? Because
Yes, yes,
psoriatic will not present
understand.
it with, yes, short of breath. But I can show the example that I ask about psoriatic association.
Unless examiner ask you differential diagnosis of inflammatory back pain, you have to mention this point.
Of course, this is very important difference. Psoriatic and ankylosing, like twins. Ankylosing and psoriatic, twins. Never mention ankylosing without psoriatic, and never mention the psoriatic without ankylosing, because they are associated, and the psoriatic itself can be presented with a type of ankylosing presentation. Thank you, Dr. Sansan, for reminding.
Okay, Dr. Basim, there is a very nice, excellent colleague, missed her exam because such case, because she did well and she didn't examine for this ankylosing spondylitis. Unfortunately, they missed all the case because this is the most important part. He thinks that his diagnosed case may be why she has going to do like this. But in the exam, they failed her, unfortunately. To be honest with Dr. Aisha and others to take care.
Yes,
Yeah.
I agree with
They
you.
are not
I
reductive jamars only.
Yeah.
I told her the first comment, you
Alhamdulillah
didn't
that
do
I did that
examination.
now.
Yes,
Okay.
exactly. So please don't do that. Whenever you know the case, try to show the examiner that you are examining the signs
Yeah.
of the disease. Like, for example,
Mm.
the thyroid, okay? You got the patient is thyroid for any reason, like palpitation, and you correlate the sign as the case I did with you, okay? And we
Yes.
correlate the signs to hyperthyroidism or hypothyroidism. What do you think if you didn't examine the thyroid? You will fail the
We
station.
should. Yes, we
It's the
should
same
examine.
here. The underlying cause is ankylosing, and you didn't examine ankylosing signs. So,
Yes.
what do you think? Yeah. So, I think, yeah, it makes sense to examine ankylosing signs in all steps from A to Z. All the 7 A's you should discover, at least 6 of them. Okay, anterior
Yes.
uveitis, aortic regurg, apical fibrosis,
Fibrosis,
amyloidosis,
amyloidosis,
Achilles tendonitis. These are 5. Aortic regurg we mentioned. I think the
Critical
bradycardia.
fibrosis.
Yes, I mentioned. So we reached 6 now.
AV block يعني.
AV block, yes, bradycardia, AV block. So this is these are 6. Someone can remind us in the chat box in order to save the time. Then we can start with Dr. May.
Hello, Assalamu alaikum.
Walaikum assalam wa rahmatullahi wa barakatuh.
So I want to share my experience for this
Sure.
ankylosing. Okay.
Yeah, sure. Yes, sure.
I have a patient with ankylosing spondylitis. Okay. When I mention in my differential diagnosis, psoriatic arthropathy, okay, they mention it for me in the feedback. Okay, even in the discussion with the examiner, they are stressing on why I'm telling this patient has psoriatic arthropathy because there is no rash, and they write for me in the feedback,
Negative.
and they even borderline for differential diagnosis, and mention he mentioned psoriatic arthropathy.
So because of no rash, why you are mentioning psoriatic arthritis? Yes. Yeah, it makes sense.
See,
Yeah,
I
it
don't
makes
know
sense.
what's written in the box that as the rash may became later on, and it is similar to psoriatic arthropathy. Until now, I cannot identify why they did it like that.
Yeah, actually, I don't know how to answer you. It's good to know that. Thank you, Dr.
You didn't say to them again is that there is no rash
Dr.
in
Ahmed.
the hand or
No,
in the hairline.
maybe, yeah. Did you say against that, for example, against that, Nora?
Why you mention it and there is no rash? Why you put it in the differential diagnosis as
Okay.
Why you mention it was ankylosing spondylitis? So what is your differential? I said ankylosing and psoriatic arthropathy, and this all these peers, all of them reacted and
Negative arthritis.
reacted for the
Maybe like the Ida, what she said yesterday, she said if the examiner he ask you what your differential diagnosis, just ask him differential لو كانت back to symptom like that you what do you mean differential diagnosis about this is shortness of breath or differential diagnosis of the back pain? Yes.
Okay.
What
the
was
problem,
the complaint?
Yeah, no, they just I mentioned all the seronegative, they just stop me in this psoriatic arthropathy, That
No,
is
you are
why.
Yeah, because of no rash.
test, even in the back test, they put it psoriatic arthropathy. One of the differential in ankylosing spondylitis. Against that, there is no rash. But I don't know. Sometimes, this is examined as human. Sometimes you didn't know what is in his mind.
Yeah. I think they need to have a rash to mention psoriatic. Apart from this, don't mention it. Okay, what was the presentation and the complaint, Dr.
Was back pain. Back pain, it was directly ankylosing spondylitis.
Okay, what they need for differential? If back pain and enclosing. So what I could put?
It was, was a typical inflammatory back pain.
Inflammatory, so I can put all seronegative.
Yeah. So when I put all seronegative, he said no. You should not put only psoriatic arthropathy by name only. The other accept all only psoriatic arthropathy.
Yes, because of no rash. Yes.
Yeah. Just
Thank you to remind us, wallahi, because sometimes we don't know the mind of the examiner. Not all are similar. So, but the mentors are mentioning both as differential for each other. But since no rash, I think better not to mention psoriatic arthritis. Unless there is even some change in the nail change or one rash, you can put it and you're sure that it will be in the correct position. But if no, I think better not to avoid and better to mention the all seronegative as collectively, not as one type or subtype of this seronegative arthritis. Thank you for sharing that. Yeah.
Thank you.
Yeah, I hope all of you share with us because We will know and we will learn from the experience more than the practice. Because as we do now, we are doing our best, but we don't understand the mind of the examiner. Even the mentors are trying their best, but the examiner wish will be different than what the mentors say. So the experience and the feedback will help us more than the mentor or practice. Thank you, Dr. Ahmed, again.
Definitely. Yes. Yes.
Thank you. Okay. Let's start the case, Dr. May. Are you ready? Yeah,
Yes.
IgA nephropathy. So the last comment, Dr. Hadil, anterior uveitis, we mentioned apical fibrosis, aorta, Achilles tendonitis, arthritis, age, young patient, amyloidosis. Yes, we didn't mention IgA nephropathy. I got full mark and my differential same. This is Dr. Sarah. Oh. Okay, if you can talk, please tell us about your case. If you can't, you can write it in the chat box. Then we can discuss it after the case will start. Yes, I will share the timer, Dr. May. Ankylosing. Okay, the case was ankylosing. And what differential you put? Psoriatic. Okay. Oh my God. Sometimes I feel the examiner, I don't know. I believe that the examiner, the male examiner, sometimes they want, I don't know, I can't say it.
Yes.
I don't know who that doctor is, she or he, the active. If you are she, so we know that the examiner pass you. But if you are he, so the problem from Dr. Ahmed. She, I told you. Wallahi, I feel the percentage of passing the females more than males. Okay. Okay, let's start. So the same differential, but you pass. But for Dr. Ahmed, borderline. I don't know. No comment. Okay, let's start, Dr. May. Full
Yes.
mark, mashallah. Don't mention because Dr. Ahmed now will feel disappointed more. Okay. Yeah, let's start.
Okay.
Here you
Hello.
go.
Yes. Hello. My name is Dr. Ahmed. I'm the doctor in the unit today. May I confirm your name and age, please?
I am Mr. Bill, 42 years.
Nice to meet you, Mr. Bill. Mr. Bill, we are here to discuss issue related to your health condition, and be sure this is meeting confidential, and I will address it to your concern. Okay.
Sorry,
Hello?
the voice. Yes, okay. Okay, I hear now. This is okay, doctor.
Yes.
Are
So,
you
Mr.
hear
Bill,
me? Yeah. Okay.
yes. Yes. Can you tell me why you are here in the clinic today?
Well, doctor, I feel I have double vision a week ago, and it is maybe sometime blurred.
I'm sorry for your suffering, Mr. Bill. And this is the first time you have this is double vision.
Sorry, again the question?
This is the first time you have this is double vision.
Yes, doctor, this first time.
This started. Did you feel it is started increased, decreased, or same?
I think it be more the blurred vision. It is now okay, but the double vision it is the same.
And what you mean exactly by double vision? Did you feel double picture, or you feel the picture or the surrounding jumping?
No, it is double, doctor. When especially when it is worse when I look to one side.
It is in one side of your eye or on both eye?
I don't know really, doctor, but when I see some thing, I see it is like double, especially when I look at the side.
So when you close one eye, did you feel this is double vision? It is improved.
I think yes, doctor, but really I didn't notice that.
No, okay. Okay. So, Mr. Bill, did you have any pain?
No, doctor.
Okay. Did you have any dropping in your eyelid?
No.
Did you feel this is double vision? Double vision. At the end of the day, it is, or when you concentrated in one specific object, it become worse.
No, doctor. It is the same all the day, and it's the same from 1 week.
Mm-hmm. Okay. And did you have any weakness in your body?
No, doctor.
Any history of headache?
No, doctor.
Any redness in your vision?
No, doctor.
Any dryness in your vision?
No, doctor.
Any dryness? Sorry, I'm so sorry for that. Any dryness in your private area?
No.
Mm-hmm. Did you have any history of high temperature?
No, doctor.
Any ear pain?
No.
Any history of weakness?
No, doctor.
Did you have any past medical history I should be aware of?
I have 2 years ago, doctor, some also problem in my eye that is continue for 3 weeks.
Mm-hmm.
I already see my GP who advised me to go to ophthalmologist and eye doctor, and I didn't get time to go, and it is settled, so I didn't concentrate about it.
It is settled by itself, or you seek medical diagnosis for that?
Really, doctor, I went to my GP, but he asked me to go to eye doctor, but I have no time. But this condition, it is last for only 3 weeks and settle by itself on
And
its
at that
own.
time, is a similar like this?
No, doctor, but really it was painful, and I firstly I lost my vision, and it is lasts for 3 hours. Then my left eye is remained blurry for about a week after.
I'm sorry for that, Mr. Bill. So, Mr. Bill, did you have any change in your weight?
No,
Any lumps or bumps in your body?
no,
Did you have any rising heartbeat?
no,
Okay. Did you have any difficulty breathing?
no,
Chest pain?
no,
Any history of cough?
no,
Okay. And did you have any lower leg swelling?
no,
Mm-hmm. Did you have any tummy pain?
no,
Tummy discomfort?
no,
Feeling sick?
no,
Do you have swallowing?
no,
Mm-hmm. Did you have any heart pain?
no,
Changes in your bowel movement?
no,
Did you have any change in your water work?
no, doctor,
Frothy water work?
no,
Joint pain?
no,
Skin rash?
no.
Did you have any, can I know what exactly your medication list?
Really, I know any regular medication, doctor.
Mm-hmm. 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 Do you have any family history of similar condition?
No, not similar, doctor. No,
Family history of high blood pressure?
no,
Family history of high blood sugar?
no,
Any family history of disease running in it?
not really no disease running, doctor. But I have my mother have some one disease that caused her a wheelchair by age of 40, and
Mm-hmm.
she be born by 50. They said that she has multiple sclerosis.
I'm sorry for that, your mother. I'm sorry. So, Mr. Bill, did you smoke?
Yes, doctor.
How many cigarettes for how long?
10 per day. This for the past 30 years.
So, Mr. Bill, I need from you to stop smoking, as smoking is bad for our health. If you agree, I will refer you to smoking clinic, smoking cessation clinic to help you regardless. How you feel about that?
No problem, doctor.
What's your job?
I am accountant.
Did you feel this is double vision affected your job and daily activity?
Yes, doctor. Really, I can't work these days.
I will help you, and I guided you to occupational health worker to help you regardless. It's okay for you.
Okay, doctor.
Did you drive?
Yes, doctor.
I need you to stop driving until I confirm it your diagnosis, and will after that we can take a decision. It's okay for you
Okay, doctor.
because it is not safe for you. You have double vision and driving.
It's okay, doctor.
Did you drink alcohol?
No,
Did you have any history of surgery in your
No,
eye or surgery in your brain?
no,
Any history of cancer?
no, doctor.
Okay. So, Mr. Bill, what's your concern?
Will I lose my sight, doctor?
I highly appreciated your concern, Mr. Bill. Let me examine you, and after that, I will answer your concern. It's okay for you.
Okay, doctor.
Okay. So I want the vital charge of the patient. Vital sign.
Okay, normal.
Normal. All of normal. Okay.
Yes,
I want the blood pressure sitting and standing.
normal.
And I want the pressure of oxygen, room air.
Normal.
Then I want to examine the hand of the patient. First, I want to examine the hand for any deformity, any flapping tremor. Then I will
No.
examine the. I want to look in the the nature of the pulse, then synchronicity of the pulse. Then I want to check for any collapsing pulse or any palmar erythema and wasting in the palm of the hand and dryness in the palm of the hand. Anything positive?
No, negative.
Okay. Then I will go up and I will check it for the JVB. Any raised JVB?
No.
Then I will examine the eye for Bell and jaundice.
No pain, no jaundice.
I want to check for lymph node in the neck.
No lymph node.
Okay. Then I want to examine the eye of the patient. Yes. Then I for visual acuity, I want to tell my patient to close his by with the same side of the patient, and I will go at the end of the 3 meters or only 1
Yes.
meter. Check it the
He can
acuity of
see. He can see by both eyes. Yes.
Okay, then I will check it
No
for visual.
blurry.
Yes, and I will check it for the visual field. I will tell my patient to close one eye. Suppose he closes the right eye, and I will move with my hand. Okay, and I will ask my patient when he sees my hand. Then I will do it in the right side. Then I will do it. I will tell my bring my hand above, and I will move one. I will close one when I move. I tell the patient to tell me what hand exactly is that moving or jumping. Then I will do is this is in the same time at the lower lid.
Okay, he has a limited in the left side. He has limited adduction of the eye. He can't adduct. He can't fool you when you when in the field. He can't fool you. He can see, but he can't fool you.
Then I will do H shape of the vision to check exactly for the muscle of the eye. I mean the third to confirm the third, fourth, and sixth cranial nerve. any
Yes,
defect.
I mean this. Yes, I mean this. He lost the adduction of left eye.
Then I will offer fundoscopy to look for any optic atrophy in the both fundus.
No need.
Okay. Then I will examine the patient cardiopulmonary. I will check for the apex and for the second heart sound, any palpable second heart sound.
No.
Then I will do auscultation of the chest, a movement of the chest and auscultation, any added sound or rhonchi or crepitation.
No.
Okay, then I will examine the back to complete with my cardiopulmonary examination for basal crepitation and sacral edema.
No. Neither.
Then if I have a time, I want to complete my CNS examination in the upper and lower limb. First, in the upper limb, I want to check it for any pronator drift.
No,
And
no
check,
thing.
yes, and I will, okay. Then I will check it the lower limb for any feature of upper motor neuron lesion according to the tone, power, reflexes, coordination, and
Negative.
clonus.
Yeah. No,
all
normal all.
Okay. Thank you, Mr. Bill, to let me examine you and sharing me this information about health condition, about your concern. I highly appreciated your concern, and from said to me and after examining you, you have a condition which is named multiple sclerosis. Don't bother about the name. It's a medical condition for medical term.
I
In
know,
which is
doctor. My mother like that. I got MS like my mom.
I highly appreciate is that we need to confirm is that from said to me and after examining you, yes, you have most possibilities that you have multiple sclerosis. We need it to confirm it or roll it out. But from the history, this is the most probably, and we need to confirm it. It is okay for you.
So I'll end in a wheelchair like my mom.
Actually, the disease itself, it is different from patient to patient. According to that, some patients, they didn't life in the wheelchair.
I really, doctor, was like that before, as I told you, and it is okay, settled. So are you really confirm that I have this condition like my mother?
From history and examination, but I need to confirm is that by doing a specific general investigation and a specific investigation.
Okay, doctor.
Okay. Did you have any other concern?
Thank you, doctor.
Okay, thank you, Mr. Bill.
Okay, time is up. Let's start the
Okay,
examiner time.
examiner question.
Okay.
So this patient have double vision. What your diagnosis in this double vision?
My first diagnosis could be multiple sclerosis in the case of a history of painful vision, which is painful vision and blurred of the vision in before in the past, and
Where
now
is
he
the
has.
lesion here? Yeah.
You mean
where is expect the lesion in this patient?
in the middle longitudinal fasciculus.
Yes, excellent. What is the differential diagnosis for this case?
My first differential could be multiple sclerosis. My second differential could be transient ischemic attack. My third differential could be stroke. Again, is that this patient had no any weakness in his body.
Any other differential?
Yes.
If it
yes.
is inflammatory?
If it is inflammatory, it could be any demyelination, like chronic inflammatory demyelination. Again, it doesn't have any weakness. It could be nutritional. It could be nutritional chronic. If this is chronic, it could be nutritional due to vitamin B12 deficiency, and it could be due to any. It could be myasthenia gravis. Again, is that I didn't have any sign of fatigability. in the history.
Investigation for this case.
Yeah. Investigation. Yes, I will do a general investigation, which is a complete blood count, renal function test, liver function test, inflammatory marker, and electrolyte. I will do a specific investigation, which is for multiple sclerosis, either a nerve conduction study and EMG to look for the muscle, and I want to looking for demyelination exactly, and then I will do investigation to rule it out. Other investigation, which is ECG and echo and CT brain.
How will you diagnose the multiple sclerosis in this patient?
والله I forget يا دكتورة عائشة.
Yeah, image. What is the image you'll do?
Yes.
What is the image? Yeah.
Yes, inspect.
MRI.
MRI, yes.
Yes, MRI. Okay, and lumbar puncture. Okay.
And lumbar puncture for longocolonal band. Yes.
Yes. Okay. Okay.
Yes.
So, how you will treat if you confirm the diagnosis?
Yes, if patient he came to me in acute setting, I will give him methyl prednisolone IV. If a patient he had in chronic state, and there is another possibility according to fill the criteria of this is relapsing remitting. If according to his gated, after that we can give him the treatment. Other that. We can give him non-pharmacological treatment, education counseling patient about his condition, and social support, psychological support, and even ophthalmologist, eye doctor, and cardiac doctor. Also, yes.
Okay. Do you know type of multiple sclerosis?
Yes. Yes, relapsing remitting, which is an progressive relapsing primary.
Yeah.
Yeah.
Okay. So for treatment of multiple sclerosis,
Yes.
You can offer biological treatment. What's complication of biological treatment?
It's against a dry mouth and some vision defect. But I'm not sure, wallahi.
Natalizumab, if specific. Zumab. Do you know complication if you use in this patient?
It is I don't know, wallahi. I don't know.
In brain.
GC virus.
Okay. Okay, GC virus, yes.
GC virus. Okay. Yes, GC virus. Thank you.
Okay. Thank you, doctor.
Thank you.
Really,
okay, thank you, Dr. Aisha, for the
Dr.
case.
May.
Yeah.
Yes, and
Yes,
she catch a diagnosis good. The history, I think it is all good, but just the double vision need more analysis for that you will see in which field you feel more double, like in when I like at the site. Also, I think the other episode, the analysis may be more to ask about what is symptom exactly, or how relieved, and which eye affected, and now which eye affected, like that. I think this all, the history all good. Even the systemic review will be more rapidly in this case. Yeah. Only the neurological you will be focused on. For examination. Okay, also in history, you should focus on rheumatology also, like inflammatory, like any vascular causes, because it's one of the most important differential here, inflammatory condition that she happened before to here, because the diagnosis before is optic neuritis. So optic neuritis inflammatory, so we will suggest also to be inflammatory condition. Okay, you can ask also autonomic systems in bladder dysfunction, impotence, for also any attack that missed for MS. You will ask also about mood, because maybe exacerbated by mood, the MS, depression. If you have also, he can affect the cognition if affect some nerves in higher function. So you can ask also on this one question, that if you have any change in mood or cognition, like that, only one question. This diagnosis of this case is intranuclear ophthalmoplegia. You can mention these to examiner. Internuclear ophthalmoplegia. When you examine, you should examine the nystagmus, because there is some finding, important finding in this case. There is nystagmus ataxic in abducted the healthy eye. The healthy eye, when you ask the patient to abduct the healthy eye, you will find that the abducted eye will be like nystagmus, because the other eye will not follow the healthy eye. You can't abduct the affected eye. Healthy affected eye is the left eye. So if you will make the H shaped, you will find there is impaired abduction. If you find the impaired abduction, you will move the other fifth to the nystagmus. So you like the test of nystagmus, you just follow the pen. He will follow the pen, and when the healthy eye abduct, you will find the nystagmus in. This is very important sign of internuclear ophthalmoplegia. This condition that, as you said, the medial longitudinal fasciculus affected in midbrain. So the conjugation between the third nerve and the sixth nerve will be lost. The affected eye lost the adduction when the other eye abduct. Okay, as the picture I sent in the group. Okay.
Okay, thank you, Dr. Aisha. Thank you.
Okay. For the differential diagnosis of this case, it is, you will be initially طبعا MS. After that, if you will, the second will be neuromyelitis optica, because also it's inflammatory and it's the same mechanism of MS, but except it not affect the brain. It affects only the brain stem and the spinal cord, and it is only diagnosed when you make the MRI. So it will be the first differential. There is other differentials like sarcoidosis, like vasculitis, like Behçet, and you ask about Behçet, I think, so you will mention in differential. Okay, maybe also vascular, but not TIA, because he has no any risk factor for TIA, and also the TIA will resolve completely after the episode, because this is the name, it's transient. So you will not found after the episode any focal problem. And this patient 3 weeks now, and or 1 week in this time, this one episode, 1 week, and still not resolved. So not TIA, just you can mention ischemic neuropathy if you suspect also from the history. But in the history, this patient, he has nothing to expect. So you will focus on inflammatory conditions, like the most probably neuromyelitis optica. There is also sarcoidosis and lupus and Behçet. Okay. For the discussion, okay, investigation for the driving, you will also add to inform the DVLA. Okay, you should inform the DVLA about you are under investigation for visual disturbance. They will explain to you what you will do, and they will recheck you again after improvement and decide about you. For investigation, as you said, and added autoimmune, as we suspect also the vasculitis here, so we'll add autoimmune. There is some condition that is defect disease or positive aquaporine for antibody. I really didn't search for it, but maybe we can search. It is, if normal MRI brain, you will maybe for neuromyelitis optica. If you found the MRI brain, also you will do, because you will differentiate between it and between MS, neuromyelitis optica. And the MS, the neuromyelitis optica not involve the brain, and the MS involves the brain. Okay. From other investigation, you will also may mention that MS diagnosis, it is 2 lesion different in space and the time. Yani you will find the old lesion and the recent lesion, and different in space in CNS. May the examiner will ask what is the most common area you will search in. It is the periventricular area. It is the most common area you will find the lesion of MS. Okay, for lumbar puncture, you also mentioned the visual potential, and this is good. You will find it delayed. There is evidence of demyelination. For CSF, you will find the oligoclonal band. It is found only in CFF, not in CSF, not in serum. For management, you will include in your team neurologist, ophthalmologist, and physiotherapist, occupational maybe. For type of MS, you mentioned good. For acute relapse, you will give high dose of steroid. After that, according to type of MS, but now the new guideline, you will start medication even if it is first episode. In this patient, we suspect this is relapsing remitting because he completely has remitting of the other episode. So we will suspect this relapsing limiting. And the option of treatment, if the examiner asks, there is IV infusion, there is injection, and there is tablet. Tablet is sphingolomide, and injection is interferon, and IV, it is the biological بقى اللي هو natazolamide. Natazolamide most important to, if he ask about the criteria, I think the criteria is hard, but he can ask about the side effect, and it is GC. So if you need to avoid this side effect, you will search for antibodies for this virus, GC virus, before the starting it, and also you will take a break, like holiday, from this medication, so you will avoid also the side effect of reactivation of this human poly, I think, I don't know the name exactly, but it is GC virus. Okay. It is the name of the disease. If he affected by this virus, it is progressive multifocal leukoencephalopathy. Okay. Other also maybe mention about interferon, what you need to do before starting interferon, like to check for TB, and what is also complication of interferon we can mention. Also, the best for the patient may be the oral treatment now, sphingolomide, and it is for now for all cases, not relapsing limiting only, and maybe from first also episode. For the patient concern, if I will be like mother, you reply good about according to your type, there is type of disease, not to, everyone have different course of the disease, but we will keep eye on you, and we will check you, and there is now some medications that can affect the progression of the disease, but you will also not give false hope that you will not be wheelchair. No, you will mention, as you said, we don't know right now what's your type of disease, but most probably you have remission before, or the disease, you are free from the lesion before. So we will also keep investigating you, and we will tell you further if with the result of our test. The other, if you ask why the disease, we will discuss only the autoimmune mechanism. And if he asks in my children like that, you said we don't know the exact cause, but maybe there is some environmental and genetic susceptibility in some people, but we don't know exactly if your offspring of your children will catch the disease or no. I think this is all. I have one picture of causes that I keep that is arranged causes of optic neuritis. If it is case of optic neuritis, now it is not a case of optic neuritis, it's double vision, so it is internuclear. But the other episode is optic neuritis, and it's common also in exam. Optic neuritis can be infectious, like bacterial, Lyme disease, and syphilis, and there is viruses like measles, herpes. All these can be cause, and the other disease like sarcoidosis, as we said, and the lupus also. Drug and toxin can cause, like the most common ethambutol that treats TB, and the methanol also can cause the methanol that some use as illicit drug يعني أو antifreeze, like some paints that they use as the اسمه ايه يعني disuse أو misuse يعني of this agent. I think this is all about this topic.
Okay, thank you, Dr. Aisha. Well done, Dr. May. Yeah, it's a high yield. I just mentioned in the previous case, MS is very common topic either in the long clinical consultation or in the neurological station. So it's a must to study this topic and to memorize all the tests and examination, either in the eye or in the lower limb or in the upper limb or even the gait. It's common topic. Okay, so let's comment from the beginning as a double vision complaint. I think Dr. May did well, but there is some specific question for multiple sclerosis must be asked. Okay, let's start from the complaint onset course duration. Is it the first time? It's a good question to ask and to know if before affected, because it might be like relapsing in such case. And it was like a clue for the case. Was it while closing the eyes improving, the lid dropping? Excellent. The timing exactly when the time in the morning or day or evening. Any redness in the eye, any dryness in the private area. Sorry for the special. Yes, all these questions were great, but the only important question, and you can correlate to the case, is the question relation to the hot weather. Do you notice these symptoms worse or comes while taking hot shower or exposure to hot weather?
Yes, this is
might
point
be
she missed, but all the
Yeah.
addition is positive in this patient.
on hot side. Yes,
Uh,
exactly.
Yes, if he has hot shower
Again,
and
Dr. Basi? Again?
Mm.
Sorry, the
Repeat it
question,
again.
is this symptoms or does these symptoms come while taking hot shower or exposed to hot weather?
maybe worsen. He will tell you that the blurred vision worsen when I
Yeah.
take a hot bath. And the
Exactly,
problem in the
yes.
hot bath, it slow down the conduction in the nerve. So it will like unmask the demyelination more.
Oh, yes. So it's not it's a matter of show. You are showing the examiner that you are asking about the disease. So how to ask about? This is a specific question. Unhof sign or phenomena while taking hot shower. Do you notice the symptoms worse or comes or whatever? And it will be the answer will be yes. I noticed that. Just to show the examiner that you are asking specifically for MS. After all this scenario, I didn't know how you say this is MS because all the question was like vague question, but this question specify the disease, and it will be like a clue for the case, along with the relapsing symptom like on and off, as Dr. Aisha did. or safe. But in the examination, nothing conclusive for MS. The tone, the power reflects it. So how you know this is MS case and how you are sure this is mostly MS? So better to ask this question to show the examiner that I got the case from this question or I got the diagnosis from this question. Okay, let's go to the other signs and symptoms of the disease. The CNS relevant system here, the weakness, the sensation, the hearing. You can ask also about the balance, about unsteadiness. So all these questions are valid in such case. You are in CNS complaint. So you could ask about all these questions to figure out your problem and what's in this patient related to the complaint. So better to ask about or full details about the CNS. The other symptoms and the other system will be quick, like cardiovascular, chest pain, nothing, the chest short of breath, nothing. Endocrine also here is very important question. You can roll out multiple, hyperthyroidism because it's one of the differential of double vision if the patient is thyrotoxic or myasthenia gravis with eye symptoms outside. So it's a target question to roll out other differential such as myasthenia gravis. So this is for the endocrine. Then the chest, the GI, sorry, for um, tummy distension, any bowel habit change. And important also to ask about the genitourinary, not the frothiness and the frequency, no, the control, any retention and any loss of the control for the water wall. This is important in myasthenia, in a multiple sclerosis patient. It might be affected. The joint, the skin, the muscle, all will be intact. But the endocrine is important. You didn't ask, you missed. Only one question: any weather prefer, or do you prefer any weather to roll out any affection to the thyroid? And the female history also here very important because you might start some biological therapy and it will be safe. You should ask for the safety for the pregnancy. Okay, this is regarding to the history taken. The family history important, yes, multiple sclerosis might be not inherited, like it runs in family, but it's not in the inherited way or genetic way. But it, as Dr. Aisha said, it's like multifactorial or it might be in the families without genetic transmission. But the siblings might be more exposed to the disease, other or more than other normal population. This is the answer for the kids, and this is the explanation of the disease in the family. Travel history, medication or medical history important here. Any long-lasting disease. She mentioned the eye problem before, and it was subsided. Why? Because of optic neuritis. Yes. This any surgery to the eye or to the brain? Good question. It might be also related. And then the HIV didn't expose any HIV in this patient regarding casual relationship or I feel that you can ask HIV for any patient, even not related, but if you didn't ask, I don't think it will harm, but better to ask. Okay, then the job and smoking and alcohol and driving, very important this because it's a direct impaction on the driving by the double vision. Patient cannot drive while he has this symptom, and you should or he should inform DVLA because it's direct impaction. But other symptoms and signs you can tell him stop driving till we reach to the diagnosis. For this double vision, immediately advise him to inform DVLA because it's direct friction to the driving, even without reaching to diagnosis because it's a vision problem. But if something indirect, you can tell him stop or I will tell you when you to drive or to inform DVLA later or no. But if the vision directly affected, so immediately ask him to inform DVLA. The constitutional symptoms also important here. Temperature, weight loss, and lumps or bumps. The examination is very important, vital, and the eye, full eye examination in the form of afro, acuity, field,
In
reflexive.
examination, sorry, about, I think the cardiac examination should take time, and I think it's not relevant
Yes,
here to
exactly.
check more than the pulse if you
Yes,
have no
exactly.
problem yet.
Even
Also,
pulse
I don't know the
will not
chest
be
here,
affected.
if it is relevant to check the chest in this case, because you also only neurological examination will take time and you
Yes,
will not finish. So if you focus on
yes,
the eye and the cranial nerve, she didn't also examine, and it is if we arrange the importance of the examination to start by the eye, then the cranial nerves.
yes, I agree with you,
Uh,
Dr. Aisha. So that's why I jumped to the eye directly. Nothing, even vital chart in a quick, any change. No, okay, let's go to the eye because you have a lot of examination. The eye started by acuity, then the field, reflexes, and ophthalmoscope or fundoscopy. And the H shape inside the field and reflexes. The H shape, as Dr. Aisha said, it will be double vision when you do the H shape. And I can repeat the examination for internuclear ophthalmoplegia. The patient will have difficult to adduct the ipsilateral affected eye, failure to adduct, and the other eye will be in nystagmus state. Okay, this is the finding of the examination. So you will move the finger away to the side affected. For example, the right, you will go to the right. So you will go to the left. So the right eye cannot adduct. So the eye will not be adducted, going to the adduction side. And the abducted eye will be in nystagmus state. This is for internuclear ophthalmoplegia. And it will not be corrected if closed eye. Okay, this is also another point for the double vision in MS. Other double vision in other stage, other situation, it will be corrected when you close the eye. But in this state, it will not be corrected. And the lesion in, as Dr. Mai said, medial longitudinal fasciculus. This is one of the CNS area. That's why the MS can affect this zone or this area, and it might be present with double vision. Okay, this is related to the H shape or the ophthalmoplegia. There is also another important test, the pupillary reflex. It might be affected or not according to the optic neuritis, which is Marcus gun pupil. While exposing the
yes,
torch or the
if optic neuritis,
yes, it
you
will
will
be
find this test positive, that is pupillary afferent, positive
exactly.
relative afferent pupillary defect. That if you
Exactly.
swing the flashlight, you will find the affected eye when you the light on it. It will not make meiosis, but if you make on unaffected eyes, you will find the affected eye can do meiosis, no problem.
Yes, exactly. So this is another finding if there is optic neuritis, but if no optic neuritis, it will be negative or it will be
Negative,
normal.
yes. Mm.
Yes. Then the examination of the tone power reflex is very important. All limbs, because it might be presented with mono or with para or hemi. You don't know the area of the demyelination. So it might be any limb. You can find only one limb, like monoparesis, and it will be spastic paresis. This is the characteristic finding in MS. Hypertonia, hyperreflexia, and the clonus will be positive. You can do the clonus. So hypertonia, hyperreflexia, and there is also weakness according to the limb affection. And the weakness because of hypertonia. Okay, the coordination supposed to be normal unless there is affection to cerebellum. And if there is cerebellar affection, because also cerebellar is one of the CNS areas. So if the cerebellum affected, the limbs will be in hypotonia, not hypertonia. And this is the only state or the only exception. The patient will in MS can present with hypotonia. Apart from this, the patient will be in hypertonia, hyperreflexia. But if he is if he has the lesion in the cerebellum, the limb will be in hypotonic state. So this is related to the tone, power, reflexes, and coordination. The sensation, all sensation modalities will be normal unless there is affection to the dorsal column. Okay. If the dorsal column affected, he will lose the vibration and the joint position. And the Rumberg test will be positive due to dorsal affection. And the gait will be spastic gait. This is related to the CNS examination in the leg. In the arms, it will be the same, tone, hypertonia, hyperreflexia, and the power affected according to the weakness, according to the limb affection due to weakness. Coordination affected if the cerebellar affected. You can do also cerebellar sign if you have time. And you can do the gait if you have time. But you should do the hypertonia and you should discover that the hypertonia, hyperreflexia, and the clonus. If you found positive
I
or
think
hypertonia,
Dr. Bassem in this case, because she mentioned no negative in history and the time is limited, maybe we will check the cranial, the eye and the cranial and finish it. And then we will go to concern. And then if we have time, we can complete. And if not complete, we will tell the examiner that we need to full check neurological examination for upper and lower. But if she will complete this examination without the concern, maybe she will lose the concern.
no, the concern is must, of course. If you have time, at least the tone and power, because you should discover hypertonia to know this is MS. Till now, we don't know this is only eye affection or eye and the brain, because you can differentiate between NMO, neuromyelitis optica, and MS. How to do or how to say this is MS without exposing the legs spasticity and hypertonia. So it might be NMO, neuromyelitis optica, right?
Yes, it's very differential already, but she has
So
now
you
no optic neuritis. Now, in this episode, no optic neuritis. So maybe the
okay,
other episode, maybe it is differential, but now you have clearly other lesion.
okay.
It is
At least
inferred
show the
differential,
examiner.
we know, but I think if you will go to upper and lower, you have no time to do because you will do the
At
sensation and the motor, both.
Yes, but the tone will be more diagnostic and more clue for the patient. Tone and power. Sorry, tone and reflexes.
And
This is the
maybe normal
most
because the
characteristic.
patient
Yes,
negative
of
for
course, I
all
agree. I
signs.
agree. By the way, I'm saying to show the examiner that you are try to discover the positive signs of MS in such case, because you might have or you might not have. I agree to find or not to find, but to show the examiner that you are searching for. Try to save the time to find the other positive finding, which are, as I mentioned, tone
Mm.
hypertonia, hyperreflexia. And you can ask for the gait and the Romberry test if the dorsal column affection. But the best or the most important to do is the eye examination, of course. But if you have time to do, try to do the tone power in the legs and the arms. Okay. Yeah, let's okay, the MS as a topic Dr. Aisha covered well regarding also the pharmacological is very important question, either injection or oral or subcutaneous. Try to know all medication we are using in MS. The types of MS, the most common relapsing remitting type, primary progressive, secondary progressive. It's so easy. Relapsing remitting, primary progressive, secondary progressive. The other question, yeah, yes, try to advise regarding the driving, also regarding to exposure to the weather or the triggers. The MRI is very diagnostic for this case. You should mention MRI, and you can say disseminating lesion different in the density, and it will show different time and spaces. And also there is McDonald criteria for the diagnosis. I think the criteria itself, no one asked in details how many meters to walk to diagnose this patient and when to start medication. No one is asking about that. But you should mention also the acute state and the chronic state, how to manage in the acute pulse therapy, high dose steroid, and in the intermittent or in the chronic, you can give what's called DMAMS, drug modified agent for multiple sclerosis, which are, you have a lot of choices. One of them is fingolimod, natalizumab, interferon beta, and I think this is common, yes. There is also one more medication, I forget. Anyway, so there is a lot of pharmacological, and try to save the time away from the pharmacological, because we are not familiar with this medication. So whenever you go to throw them in details, you will be in trouble, because we don't know a lot of side effects. The common side effect we know, yes, we know about them, but there is also, or there are some other side effects you don't know, and the examiner might ask you. So please don't take long in the pharmacological. Try to talk more in the investigation and in non-pharmacological management. Okay, I hope we covered the topic. Well, it's a high yield, as I said. Let's read the comment. Before any question, any comments? Neuromyelitis optica is different of MS, but optic neuritis occur more than myelitis. Yeah, she asked about female history. No, she didn't. Visual evoke potential, not forget. Yes, I agree with Dr. Sousan. This is other investigation and diagnostic tools. By the way, Dr. Aisha, don't say to the patient, we'll do investigation, or Dr. May, after doing some investigation, because the investigation itself is jargon, so you can say workup or blood tests or scans. The LP for oligoclonal bands, yes. Diagnosis usually with MS protocol. You can say this. This is a general term you can use. Sensory symptoms and sphincter control and unsteadiness is very important. I agree. Acupurin, McDonald criteria, yes, Dr. Hassanin. VIB if eye symptom is lonely. Treatment say it by crisis or maintenance, yes. GC virus, PML for natalizumab, yes, characteristic. NMO occur in age younger than MS, and usually optic neuritis in NMO irreversible damage in optic nerve, so it must be treated urgently to prevent permanent blindness. Anhoff, yes, we mentioned Anhoff sign or phenomena. Lower limb extension is most important than cranial nerve, and also cerebellar important. Yes, I agree for this. Cranial nerve is not common affected compared to the lower limb. So to do lower limb rather than doing cranial nerve, unless there is affection to the facial in front of you. Even the facial will not be
Yes, I know, but
commonly.
because the lesion is here in one of
NMO. Yes, but patient, by the way, the
you will
spasticity may be
maybe you will
preserved.
exclude the other if it is
I agree,
intracrine
Dr.
lesion
Aisha. I
pressing the
agree.
nerve or medial
I agree
meniscus.
to do the eye, but at least do lower limb examination. Most of the
Okay.
most of the
The eye is
patient with MS,
important. I mean, other cranial nerve.
yes,
The eye is important. Yes.
The
Yes,
eye
I
and
agree.
يعني
It's in
we
the
will
eye.
start by lower ولا cranial
No,
because
no, no, no,
in
no,
my
no.
exam I think I need to focus.
Eye
Ah,
examination, full eye examination. Then the
yes.
lower limb. Then if you have time,
Then lower
cranial
limb.
nerve.
Lower
Yes.
limb only tone. Only tone
Tone
or
or
tone and
reflexes.
reflex
or
and Fabinski sign for pyramidal.
Reflexes.
and the gate.
Reflexes.
Okay.
Reflexes, yes.
بشيل دعم من نجاح activation
In also in notes of this case هي mentioned
بدول anti platelet وما في حاجة
Sorry?
someone talking.
No, she's not talking to us. Okay, Dr. Aisha, what's your comment?
He mentioned also to do the what is this cerebellar test like pointing, I think pointing like that
Finger nose.
finger point. Yes, he mentioned
If
to
the
do it
patient
also.
Yes.
has
Yes.
unsteadiness, yes.
If there is,
Nystagmus
yes.
and yes.
By the way, you can do it in the history taking, and at the end you can offer it to the examiner. Okay, if you don't have time. But if you have a lot of time, you can do whatever you want, starting from the eye, then the legs or the lower limb, then the hands, cranial nerves, and cerebellum. Okay, and this is these in order. So the eye, full eye examination, then the lower limb, upper limb, cranial, or cerebellum before the cranial, especially if there is unsteadiness in the history. And the cranial, you can summarize your test in the cranial for one nerve, which is how to examine, or if the examiner give you time to examine one cranial nerve, which nerve you will examine?
I think
Dr. Aisha.
trigeminal fifth it
Why
is more the
trigeminal?
most common. Huh?
Okay, but if there is a chance to localize the lesion in the brainstem or in the brain, what nerve you will use?
Localizing
The facial
lesion.
nerve. Yeah, the facial nerve.
7. Okay.
Yeah, 7 nerve. This is the commonest and the most diagnostic nerve to examine in the cranium. Yes, exactly. Dr. Hassan mentioned 7th nerve or facial nerve. Why? You can localize the lesion either in the brainstem or in the brain as upper motor neuron or lower motor neuron. How? You know, Dr. Aisha, how?
Sternomastoid or which
No,
muscle? Or
the face, the face itself, the face, the upper
is the
half.
forehead
Frontalis.
involvement or no? In forehead?
Exactly, yes.
Okay.
The upper motor, the face, the half or the upper part of the face will not be affected. But in the lower motor neuron, the whole face will be
Whole face is affected,
affected.
yes.
Yes. So this is diagnostic and target examination in the cranial nerve. Okay. Forehead, yes. Forehead will be spared in the stroke. The stroke upper, but the upper will not be affected. So upper, but the upper will not be affected. Lower, and the whole face will be affected. Remember that. Upper motor neuron, but the upper face will be spared. Lower motor, but the whole face will be injured. Okay, thank you, Dr. Hassanin, and thank you, Dr. Hadid. Thank you, Dr. Mai, Dr. Aisha, all of you. Any comment, any question before ending this session? Any question, any inquiry? Okay, if no question, we can end this session. Thank you for attending, and we'll see you tomorrow. Good luck and good night. Assalamu alaikum. Thank you.